let's get things started. So what we'll do here, again, topic is going to be digitizing DSOs, the clinical and business benefits of digital technology. Shout out to Carestream Dental for sponsoring this podcast. We appreciate it. We are going to let Ryan Roosekrans, he is the 3D imaging specialist at Carestream Dental, give us a little bit about his background. Ryan, take it away.
Hey guys, thanks for having me. It's a pleasure to be here with you today. Thank you for your time. I am the senior 3D specialist with Carestream Dental. I've had the real pleasure of specializing in dental CBCT for, gosh, the last over 15 years, really almost since it really kind of came into dentistry. I've run dental cone beam imaging centers, both here in the US and overseas. And at this point, I'm putting all that experience to good use with Carestream. So again, pleasure to be here.
Thanks, Ryan. Next up, we have Dr. Daniel Fenton. He is the Director of Clinical Education and Training for Affordable Care. Affordable Care is the largest DSO in the country within the realm of tooth replacement services. So, Dr. Fenton, thanks for being here today. Please touch on your background a little bit.
Yeah, good afternoon, everyone. Humbled to be here, and I just wanted to piggyback off of what Ryan said, and enunciate the importance of education. I think that I can speak for all of us when I applaud you all for taking the time out of your busy schedules to attend. And I think investing in yourselves and the CE process is extremely valuable, especially in the world of implant and restorative dentistry. So I look forward to the dialogue to follow, and I appreciate the invite.
Last but certainly not least, we have Dr. Sundeep Rawal. He is the Senior Vice President of Implant Support Services for Aspen Dental. And actually, Sundeep is just back. Aspen had their leadership retreat, so we are fortunate to have him here today, and he is based in Chicago.
Yes, thank you. And like everyone else, just thrilled to be here to talk all things technology and how it's affecting what we do and offering care to patients. Now, a little bit about myself. I'm a prosthodontist. I was blessed to be able to start my career when technology was really permeating all that we did and really affecting how we offer care to patients and innovating to allowing us to accomplish our goals in just better, faster, and more predictable ways. And so I've spent a lot of my career educating across the industry, and the last few years now I've been with Aspen Dental, focused on dental implants and the technology that supports it.
Excellent. So what I'm going to do is I'm going to stop our little screen share here for at least the time being, so you can actually see everybody. Let's see if I can do this without shaking things up too much. Oh, I see Kristen there. Oh, we're going to have to get rid of her. There we go. All right, wonderful. So we've got everybody here now, all the panelists. So let's do this real quick. I wanted to get into the Q&A, and what I wanted to do is start with the docs. You kind of a relatively basic question, but I think it's something, from the standpoint of DSOs. A lot of DSOs are still using 2D technology. So let's talk about moving from 2D technology to 3D technology, and how that enhanced things for the DSO, and talk a little bit about that changeover. We can start with Dr. Fenton.
Sure. When you think about efficiency, kind of divided into two different buckets for what it did for us. I think there's an economic component to it, and I think there was a clinical component to it. And it surely changed the landscape of our practices from an economic standpoint. When you think about two-dimensional film use, there's no disposables involved. Whereas with the two-dimensional film, you've got overhead and inventory affiliated with fixer, developer, as well as the increased and greater chance of human interaction, which is a variable that is going to increase your chances of unpredictability. Whereas clinically, you've got, it's ubiquitous to various team members that can use this instrument, right? You don't have that one or two dental auxiliary staff that's the X-ray person. Depending on what state you're in, you may need some certification, but we've got cross-trained individuals in our practice that can take an X-ray, at any time at the drop of a dime, and not having to be educated or proficient with the film technology. So from an efficiency standpoint, clinically, it's made a tremendous difference. As dentists and dental auxiliaries, time is our biggest commodity. That's the one thing we can't get back. So in terms of time efficiency, it's a no-brainer as far as what your image is going to portray in a CT machine and the amount of time versus in a 2D conventional image. And it ensures safety and predictability, which I think are the two paramount things that you really got to look at when utilizing 3D imaging. So in terms of efficiency of your treatment plan and the results, there really is no comparison to 2D versus 3D. It's hard to picture how life was when utilizing 2D technology. Looking back, it's impossible to even think that I placed an implant or did place an implant, but it is still teeter-tottering on the standard of care. I don't think we're there yet as far as 3D technology being the standard of care when you look definitionally of what that means and when how it's set by the majority. But I certainly think we're on our way, and rightfully so.
Let me ask a question, Dr. Fenton. When was that transition made, the 2D to 3D at affordable? Was that something that was done a while back, and how did that, what would that look like? And then I'd love to get the same feedback from Dr. Rawal as well.
Yeah, so I inherited the partnership with Carestream. I came on board as a practice owner in 2016, and that was right when we were converting the offices into 3D cone beam utilization. So I have been using it for 5 years, but I think that partnership started a year or two prior to my onboarding. So that decision was easy for me because it was made for me.
Great. Dr. Rawal?
Yeah, I think I can echo a lot of what Dr. Fenton was talking about in terms of the valuable nature of three-dimensional imaging. Look, there's no doubt. I mean, we can certainly debate whether the standard of care is codified medical, from I guess a legislation standpoint. But the reality is I think medical legally, we all agree for a long time now, three-dimensional imaging, especially for diagnosis and treatment planning, has been not only optimal care, but in many respects is the standard that we all kind of hold ourselves to. I think from the standpoint of adoption, I was very lucky and fortunate in my career to adopt CBCT technology pretty early on, back in the mid 2000s. And so coming out into practice, being accustomed to that level of diagnosis and treatment planning, as Dr. Fenton said, you can't go back once you start down that path. I think at Aspen, we saw this vision quite a number of years ago, where we realized that the ability to not only diagnose in 3 dimensions, but the ability to then use that information for relevant, clinical decisions, and then actually go to clinical operation through technology and software was where the industry was going. I mean, if you think about where we are today, I think we could all agree that a CBCT scan is not just for diagnosing measurements. The CBCT scan is a valuable piece of 3-dimensional imaging that we can then take that data out and utilize it to not only diagnose care, but actually to affect care and how we operate. And so from that standpoint, knowing that we can do that across multiple verticals today, whether it's dental implantology, whether it's endodontics, oral surgery, orthodontics, just the list keeps going on and continues to grow year in and year out. The reality is it's an incredibly valuable, and I think at this point, mission critical tool for us to have success across patient care. So we saw this vision early on. We've been in the midst of our CBCT program for a number of years now. And, we're at this point close to almost 80% adoption across the entire network with CBCTs in every office.
So the question would come up for, especially if DSOs still using 2D, the cost, right?
Sure.
So it's a big investment, especially if you're going across 10, 15, 20, 100 practices. So let's talk a little bit about a cost benefit analysis, how you make that decision. A lot of different options out there. So Sundeep, talk a little bit about that. What when it's in technology.
Yeah.
Go ahead.
Yeah, I get it. I mean, look, I think the first thing is we have to really qualify what ROI for technology is, because traditionally, let's call it, or conventionally, our thought process around an ROI analysis is always boiled down to, well, how much does this piece of technology or process or protocol, how much is the investment in that? And then how can I monetize that? Meaning, let's take a CBCT, for example, what's the cost of the unit? And then how much revenue can I churn off that utilization to justify the cost? But I think really when you think about technology today, that conversation is very limited to what the breadth and scope of the technology and the applications we have allow us to do today in terms of ROI. So when we look at ROI and we look at analysis across what will gain us the maximum amount of benefit for looking at a technology or making the investment, you have to think about this conversation not just from what is the monetization at that one point in time of utilizing the technology, but you have to look at it across the entire spectrum of care, from diagnosis to delivery. And a really good example is if I can use CBCT imaging and layer it in, let's just say in software with intraoral scans, with facial scans, make really good sound virtual decisions and affect care in that. And let's say it's an implant case, and we're going to go through a guided process to place implants. If we can do that, and through that process, it saves us one clinical visit compared to a traditional non-three-dimensional basis. That one clinical visit of chair time, operational time, patient flow, getting more people in the door, faster access to care for other things while your time is freed up. Those returns on investment need to be calculated into what's the cost benefit of actually the acquisition or the initial investment of the equipment or the technology. And so when you look at scale across that, it's a pretty compelling discussion, whether you're a 5-office support network, if you're a 50, 500, it doesn't really matter your size or your scale. What really matters is, are you utilizing the technology to the fullest? Because if you are, across all of digital technology today, across multiple modalities, there's a pretty easy case as to where that investment comes in. So I think that the key to doing a really good ROI analysis is understanding what the full application of the technology is, right? And then are we prepared to utilize it to the fullest? Like, do we have the skills, the technology, the experience, or the infrastructure to be able to leverage the benefits to the maximum? Because if you are, then you can make a really accurate and a true analysis of what the return on the investment is.
Yeah, some great points. Dr. Fenton, I don't know if there's anything you wanted to add to that.
Yeah, no, just I agree with Dr. Rawal. I think that it's a little bit twofold in terms of ROI from a scanning standpoint. You're not really acquiring the machine to get a return on the volume of patients that you're scanning. That's not really, in my opinion, where the value comes from. It does, however, help you during the consultation phase, where you're legitimizing the seriousness of your patient, where if they balk at the cost of the CT, it's kind of an indicator financially or via the perception of value if they're going to move forward or not. So it does prove useful in that way. However, I think there's more intangible value and analysis when I think about the cost of the CT and its efficacy from a clinical standpoint. I think that it's a question you have to ask yourself of, what's the cost of providing the best treatment to our patients? And I think at the end of the day, that's what we're all after, whether it's private practice, whether it's a DSO, whether it's an educational institution. We want to put our patients in the best position, and we want to put our clinicians in the best position to succeed with the tools that they're given. So I think you have to ask yourself, what's the cost of the confidence level that you're able to perform this procedure at, right? Are you gonna launch or be more confident by having this unit in your office? And then how does that translate to your ROI if you're able to expand your service line because of it? What's the cost of litigation if things go wrong by not using this machine, right? So I think there's a couple holistic pieces to the puzzle as well, besides strictly thinking of it as a monetary jump, but all are important, and all get you to the finite answer that it's certainly a benefit and an advantage to adopting this technology.
Yeah, so great points from both Dr. Fenton and Dr. Rawal. It kind of leads into the next thing, and Dr. Rawal kind of mentioned, are you really utilizing all the technology that's available? And Dr. Fenton, you talked a little bit about the confidence level, right? So beyond the actual product itself, right? What kind of training is available? What kind of support is available? When a unit goes down, I mean, who's going to be there to help service it? So let's talk a little bit about that. I'd love to kind of get your feedback, about where do you look at? Would you look at, the unit itself? Do you, the technology itself? Do you look at the company behind it and what they provide? What seems to be, the right formula? So Sundeep, if you want to start.
Yeah, I mean, look, I think from my perspective, you really have to look at, the technology and the companies that you're looking at in terms of what are the possibilities out there. I think it's really important that when you look at technology today, you don't look at it as a standalone entity in the process, let's call it, because the reality is, I think we're very well entrenched in this concept that we live in a digital dental or digital dentistry world. But what it really means, like not unlike or not too different than living in an Apple world or a Samsung world, is you live in an ecosystem. And it's so critical that when you're looking at these technologies, that you're looking at it from the perspective of how does it fit into my overarching ecosystem? And that ecosystem certainly means clinical, and where's the workflow, and what does the technology allow me to do to maximize the full breadth and scope of clinical capability. But then I think, especially from a support standpoint at scale, when you look at DSOs, you have to look at how does it fit into our overall ecosystem? How easy is it to integrate the technology and use it to the fullest, right? Not integrate where I can have some functionality, period, right? And it works, but it's more integrating to the fullest where I can maximize the breadth and scope of what the capabilities are. And at the same time, do it in a way that's easy, that's efficient, easy to train to, easy to operate to, easy to scale across a wide network. And those are really the kind of qualities that we look for when we evaluate technologies and look to companies to see what partnerships to form, because there's a lot of variation in the market today in terms of how easy it is to utilize the technology, to integrate that technology, operate at scale within your own ecosystem. And what works really, really well for, let's say, our offices at Aspen may be just different from what Dr. Fenton's group can do in his DSO, because the reality might simply just be that their ecosystem is different than our ecosystem and set up in a way that one partner may make sense versus another. So you have to look at broad strokes, and you have to be able to say holistically, what synergistically will work well with what we're doing from the standpoint of integrating into our existing world, allowing us to get enhancement or value out of that, and then being able to then hopefully, utilize it to the fullest. And then you see what partnerships are out there that can be beneficial in that endeavor.
It makes a lot of sense. And you mentioned something, Dr. Rawal, Dr. Fenton, maybe you can take this from a scalability perspective. How important is that for affordable, or just in general for anybody that might be vetting potential partners?
Yeah, I think that those two questions are married nicely. I heard something funny the other day, and I'm not sure if y'all have experienced it, but it seems like everything is on back order, and some of these dental forums, everyone's kind of complaining and concerned. And one of the comments was, and so is customer service, right? That's on back order too. So, to your point and the question, I think that choosing the right partner and the education is a tremendous component to making this decision. And I think it ties in very, very closely with scalability, because the functionality of the instrument is completely related to the proficiency of the user. And Carestream is been a great partner for us in that way. We've had after hours training, we've had weekend trainings, very, very accessible. Not to mention, you know, they're an A-list brand, but from a scalability standpoint, their platform is very intuitive and it's a very user-friendly system. And I think when trying to, you know, cross-pollinate this technology in a larger multi-office type of format, that you need to look at things like that, right? Because not everyone is going to be tech savvy within the office. And I think that that universal acceptance and application of their specific software went a long way for us. And that's one of my favorite things about it, is that it was very intuitive, it was very user friendly, and they were always accessible when we needed some assistance on the side.
Thanks, Dr. Fenton. Ryan, so we don't want you just sitting there not with anything to say. I know you've got a lot to talk about here. So why don't you talk about it from your perspective? You work with a lot of group practices, different sizes, right? You know, a couple locations all the way up to, you know, the scale that an Aspen or Affordable has. So when they're looking specifically from a 3D perspective, talk about, you know, what should be considered, and then the implementation of that as well.
Yeah, sure thing. I mean, when it comes to selecting the right digital partner, you know, the digital product itself is really just the beginning, as the doctors have said. Service and support is huge, education is huge, and it has to fit with the DSO, and, you know, not just be like a cookie cutter like you would use for private practice. You know, you really have to understand the environment. You know, with Carestream, we're really proud that we do have dedicated DSO support teams, you know, separate from our standard support teams that are available just for the DSO practices. And we, you know, again, you have to look at, you know, things like the support hours. You know, we're pleased to be able to offer support from, I think it's 8 a.m. to 8 p.m. Eastern, maybe 8:30 Eastern, you know, Monday through Friday. You've got to be able to respond. Response is huge. When it comes to DSO, if there's any kind of problem or issue or anything that needs to be addressed, you know, are you going to get a response? You know, that's something that you definitely need to look at. But, you know, the experience that we have and the understanding that we have, that we've gained from working with Dr. Rawal and Dr. Fenton and the DSOs, you know, you have to understand that it is a lot different than dealing with, you know, a private practice. And the scalability is huge too, education and training on their terms, you know, on demand. And that's something we're really pleased to be able to offer. We've got our Carestream Dental Institute, which is available to any of our customers 24/7, with hundreds, if not thousands of hours of recorded trainings and webinars, you know, that you can, again, use on your terms and on your time. Now, Bill, were you asking me also specifically about, you know, when you're looking at deciding on the equipment as well?
Well, I mean, I think that, yeah, that's actually a really good question. I mean, there are a lot of factors involved. There are a lot of players in the market. I am sure it can be overwhelming, and I'm sure that there are some that probably don't have the offerings specifically from a scalability perspective. So talk a little bit about that, if you don't mind. You know, what you feel specifically a group that's either looking to scale or has gotten to scale needs to pay attention to.
Yeah, absolutely. It's a big decision. It's one of the bigger decisions in a dental practice. You know, the X-ray unit and the cone beam unit, that kind of thing. And the first thing, this is a big question, but the first thing I would say is definitely not all cone beam units are the same. And we also have to look at a lot more than just image quality and resolution. You know, that's one of the big things that gets talked about first and foremost, but you have to, you know, again, considering from a DSO perspective, we have to really look at a lot of other factors. We almost have to examine it from, you know, the top down or the bottom up. You know, a big one is ease of use of the machine and workflow. You know, if a unit is too complicated or overly complicated, your staff generally won't use it or use it properly. You know, you need ease of use. You need easy workflow. Some examples, just, I could go on and on and on about these things because, again, you really need to consider every factor when you're looking at cone beam. But just some examples. There, one of the things I like about Carestream units is that it's all face-to-face positioning. There are other units out there that's not like that, and they're on the cheaper end of the spectrum for a reason. There's units out there that have the patient positioned in the machine facing the wall or facing the column, and then your staff has to stand behind their shoulder, looking over their shoulder into a mirror, positioning them with lasers. I mean, it's ridiculous. I mean, it's a recipe for bad images, things like that sometimes you might not consider though, are the ease of your staff to be able to properly position the patient. Things like, I like that Carestream acquires their images in a native DICOM format as opposed to a proprietary format like so many others do, because DICOM is like the JPEG of 3D imaging. It's the universal format. But if I'm working with a machine that takes their images in a proprietary format, which I used to do in my early imaging centers, it's a 6-step process to export those scans to DICOM to be able to use, to share, to be able to use in a different application. And it's things like that that have to be taken into account in a busy DSO environment. Field of view is important. You want a machine that offers a field of view for each and every one of your patients and each and every one of the treatments that you're looking to perform. You don't want to have to fit your patient into a less than useful field of view, and so you have to consider all those things as well. I mean, resolution is huge, but it's not the only factor. It's definitely huge. You can't treat what you can't see. And at the end of the day, that's really the most important thing, is what you're able to see and what you're able to diagnose and treat based off of the images. But it's not the only factor to consider. And I mean, that's the short answer, Bill. There's lots and lots. Like I said, you need to look at it from the top down, but those are some key points.
That's great. I appreciate that. So it's funny. I said to the attendees that they can either ask a question in the chat or ask a question in the Q&A, and one just texted me. So they didn't listen to the instructions, but I know who they are, obviously. So here's the question. I kind of want to throw it out there, and it's for the docs, but the question is there an expectation from clinicians that the technology is 3D now? Sundeep, if you want to start that off, that was the question.
Well, I think, I guess the best way I can say it is I think there's an expectation for clinicians that the technology that we utilize in our offices is innovative, is not outdated, or obsolete for that matter, right? And I think that there's a real expectation across the board when it comes to everything that we do, that we continue to strive for excellence in optimizing patient care. Then we have a mentality and a paradigm that we will, innovate at the front end of innovation, right? Not, maybe bleeding edge, but at the end of certainly the leading edge, right? And so at the end of the day, when you frame that kind of expectation from clinicians today, then certainly 3-dimensional imaging is part and parcel of that. I think there's no doubt in my mind today that even the dental student graduating tomorrow from dental school has an expectation that 3-dimensional imaging is certainly a better way of diagnosing and treatment planning than 2-dimensional imaging. And so from that standpoint, the reality is absolutely, I think it's important to clinicians. And I think there is a real expectation that we continue to improve on what we do today for the betterment of patient care tomorrow. And the reality is if you look at imaging and diagnostic criteria for radiographic imaging, I mean, there's a clear, stark divide today between 2D and 3D. It's not, I don't think the industry is where it was, 10, 15, 18 years ago, where we were like, 3D imaging is nice, but, maybe it's an enhancement that may help, but not mission critical. I think today there's a clear divide in the industry where we know today that 2-dimensional imaging for radiographic analysis is not really where we all want to be. It's legacy, obsolete, certainly not innovative in any way, shape, or form. And then I think when you think about what you can do today with 3-dimensional imaging outside of just radiographic analysis, right? Because with 2D, it's only radiographic analysis. There's nothing else you're doing with that information. You're not taking a FMX and like importing it into software that allows you to actually do dentistry, right? So when you think about the utility in 3D imaging today, it's a no-brainer. And so I think there is an expectation when you have this kind of stark divide between, previous iterations of technology and I don't really consider it even new, just kind of today's most contemporary iteration of technology. I think there's a real expectation for clinicians that we're going to be forward thinking enough to embrace those.
Dr. Fenton, I don't know if there's anything you want to add to that. And I'd be interested to also hear your perspective on, does it, one of the huge issues, right, if not the biggest issue, maybe besides supply chain issues, is recruiting, right? So is this something that can be used as one of the tools in a toolbox to help enhance, hopefully a young clinician coming over to Aspen or Affordable because of the technology that you offer?
I believe so. I think as clinicians, we have expectations of exceptionalism, or at least I'd like to think so. And we live and breathe in a area the size of a golf ball, right? The oral cavity. So we live and die by fractions of millimeters. And I think that especially in this generation, new grads are coming out and they're hungry for that technology. And there's an expectation on their end as well to want to be immersed in the latest protocols and workflows and advantages to make their treatment ideal. From a 2D versus 3D expectation, it's it's black and white to me as far as the analogy to compare a GPS in a modern day car with how people got around in the past with a two-dimensional paper map, right? You're still able to get to where you want to go with that paper map, but there's an increased likelihood of possibly taking a wrong turn or still getting lost, right? Versus the 3D imaging symbolizing a GPS system, and I think that plays a role. I think that your precision, your accuracy, and the quality of care you're able to deliver to your patient is evident, and then I think that's what we all expect at the end of the day.
Laugh about the paper maps, but I remember those. So you going to GPS, it definitely helped. Of course, now I don't know north from south because of having a GPS. I've got a good question that just popped up here. Have you seen challenges? This is right along the lines of recruitment, but it's kind of flipped on its head, right? So it's the seasoned docs. Talk about challenges of onboarding some of the seasoned docs with technology. So then the ones that say, hey, I'm used to 2D or some other type of technology, and kind of making that transition over. And I think Ryan could even touch on this too, because it might be interesting to talk a little bit about your perspective on this. So Ryan, why don't you start off? Have you heard any feedback around in trying to onboard seasoned docs and how that looks?
To be polite about it, I mean, it can be a challenge. Once you've been doing something a certain way for 20 years or most of your career, or a long time, it's hard to change sometimes. And so, I can only really speak about it from Carestream perspective, based on my experience. But we do everything we can to set everything to where anybody can learn it. We really try to make our software very user-friendly, very easy to use. We've got it color-coded, so it's very difficult to get lost. I know it's different than what you may be used to looking at, and making the jump from, especially mentally from 2D to 3D can be challenging as well, but I mean, so rewarding, and so we really make a lot of effort to make everything accessible for everybody, but I know there's inherent challenges there.
Yep, I'd love to hear from the docs, Dr. Rawal. Any issues from season? Any pushback or?
Yeah, I mean, I think what it really boils down to is a couple of things. One is when you are going to introduce anything new, like there's change, right? And we all know how people are when it comes to change, and the natural instinct is to be resistant to change. And so I think when you start looking at introducing anything that's new, and it's an innovation or technology, product, software, equipment, first off, you have to have a compelling narrative as to why Like, why are we doing this? Like, what's really the benefit? And I think that in today's world, especially for the seasoned clinician, it has to be a multifactorial narrative as to where there's clinical benefit to be able to use this, where there's operational benefit, where there's benefit to team and systems integration and processes and protocols. There's got to be a lot of value in what we do, when, especially when with regards to a seasoned veteran and how we approach it. I think the bigger thing though is we can create the narrative all we want, and we probably will get initial buy-in, but you have to then be able to actually implement. And the first key to that is training and education. So having robust training and education supporting the initial journeys of people with new technology is absolutely critical. It's one of the things that I know in our history with Carestream, we've done a really great job of building, strong clinical curriculums around the technologies that we want to use. And then I think not only do you need to have obviously the clinical training, but you have to have operational training and education. And then you have to have strong implementation teams that can make sure that as you go and do this, especially at scale with seasoned clinicians, that you create a seamless experience for those doctors. So, if you have a clinician who's extremely seasoned, you build the right narrative that shows benefit across, multiple different facets, and then you can actually deliver on that promise. You can go out and implement and utilize good quality training and education across doctors and teams, have great operational sense and implementation success, where the entire process gets bundled into something that's seamless. That's where you get seasoned veterans to be able to come on board a lot easier than if any of that part falls apart, which, in totality, that recipe is kind of a tall order, so to speak, right? It's not exactly easy to check all those boxes at the same time. But if you get it right, you certainly do get great adoption from those seasoned clinicians.
Yeah, Dr. Fenton, what's your experience with seasoned clinicians?
I agree. I think that once the perception of value is achieved, I've been pleasantly surprised about the adoption of our seasoned, or dare I say older clinicians. If you look at the natural evolution and attrition across industries, whether it be from our cell phones, or from the way that we order our food nowadays, we've been thrust into situations where these older demographic or seasoned individuals have had to adopt the technology, and they are, and it's an invigorating thing to see. I think that we touched heavily upon the capabilities of the machine for measurements and for fail-safing, but what I've seen with the seasoned docs also is that the capabilities of the CT machine, in addition to surveying the land, so to speak, and helping diagnose certain pathology, is the ability and the cross correlation it has with manufacturing, right? The utilization of this machine to help fabricate digital dentures, clear aligners, surgical stents, right? So it has given these older, more seasoned dentists a little bit of a more zest for dentistry, and reignited their passion, to do more procedures because of this, new wave technology.
So, Dr. Fenton, while we're on you, talk a little bit about using 3D technology and maybe the types of treatment options you're able to offer that you weren't able to offer. Maybe you can provide better care with 3D, or diagnose things better. Talk a little bit about that.
Yeah, I think as a whole, it's just really been an enhancement from what we've been exposed to before. I don't know if there's been a new service offering. I think that it's been a catalyst that has supplemented our product line and given doctors resource to improve the products that are delivered. So it hasn't really reinvented the wheel, so to speak. We're still fabricating the same types of prostheses, but the predictability and the accuracy and the precision and the confidence behind which they're performed has exponentially risen.
So, Dr. Rawal, specifically with standardization of surgical guides at Aspen. Talk a little bit about that and how that's affected implant placement.
Yeah, I mean, look, we've had a strong, because of the partnership that we have, obviously with Carestream and the associated companies and their workflow with guided surgery. It's made it really efficient for us to scale up the concept of guided implant placement. I think we all agree today that some form of guidance, and by definition, guidance being diagnosing and treatment planning in 3 dimensions, which necessitates CBCT, in software to make relevant decisions on clinical care, and then somehow, some way operating to plan, right? It doesn't mean flapless. It doesn't mean fully guided. It doesn't mean that, you're using just only a static mechanism. It could be dynamic for that matter. The reality is, though, this notion that guidance when you're operating for implants enhances outcomes. Plain and simple. Implants go in more accurately based on where they should be placed, i.e. to plan. And because of that, the outcomes for patients with implant dentistry is enhanced. You get more predictable prosthetic restorations, minimize chances of complication, minimize long-term chances of maintenance issues. There's just a variety of things that if we put the implants in the right spot, the rest kind of trickles into place. So this concept that guidance can be of a huge support mechanism for implant dentistry is just, at this point, I think, something that's a pretty common theme in the industry. And it was very important to us that we adopted the same philosophy. So with the work that we've done, with Carestream in being able to streamline the process to effectively be able to diagnose, treatment plan through a guided perspective, print surgical guides, have that ability to offer patients that service in a predictable way that we've been able to scale across our network. The reality is the results are astounding. Doctors' confidence goes up because obviously they're being able to place implants in a way that gives them the assurance that what they're doing is in line with what they were thinking they were going to do or what their plan was. It allows them to treatment plan more confidently because not only are they able to show value to the patient from the standpoint of utilization of technology. I mean, we all live in an iPhone world today, and patients don't expect their healthcare providers are at least as contemporary as they are. So it helps with acceptance, but it even increases the confidence that the doctors and teams have with offering these services to patients. So it's been a tremendous benefit to us to adopt guidance as something that's a paramount part of our implant program, because the reality is it not only is just the best thing for patient care, but it allows us to do more of that care for patients. And that's not even taking into account the efficiencies you gain when your surgical times go down. There's less time to teeth, the ability to minimize the chance of having to do additional steps later on because of an error during placement. There's just so many other tangible returns on that investment that it was a high priority for us, and we've seen great success with it over the last several years.
So let's just talk about in generalities. I mean, are you doing 3D scans on all or most of your patients? Dr. Rawal, you can start off. I'm kind of curious, and then I'd like to even get Ryan's feedback from perspective. What are you doing currently at Aspen?
Yeah, I mean, look, I think we espouse that any time that a three-dimensional analysis is needed, we take one, right? I think the reality is what we kind of think as an industry and paradigm standpoint of what is needed has changed a lot in the last 5 to 7 years, right? I think just this notion that, do you need a CBCT to place an implant or not? Clearly, whether it's legislated as standard of care or not, there's no doubt in anyone's mind that to operate for a dental implantology, you should be diagnosing with CBCT imaging. That's our philosophy, and that's something that we do for every single patient that would potentially need potentially need a dental implant, right? But that list starts to expand. If you think about endodontics, right, and you think about what we can do to treat an endodontic issue in 2 dimensions versus 3 dimensions, certainly is the argument to be made that we certainly should be looking at every single endodontic patient in 3 dimensions. Same thing with oral surgery. If you're going to take out an impacted third molar, or you've got a tooth that may be multi-rooted or what have you, you got to be able to sit there and make good clinical decisions based on what your surgical goals are. Again, 3-dimensional imaging plays a role. And so it's not something where we would, I would say that every patient that walks in the door gets a CBCT scan. It's every patient that really needs to be diagnosed and imaged in 3 dimensions. We have the ability now across most of our network, and soon to be hopefully all of our network, to be able to utilize that technology. So now the reality is as an industry, how many of our patients do we think really need this technology? And I think what we're seeing is it's not really this niche application that we use for just the most esoteric implant when it's a very thin ridge, high smile line aesthetic case and we need to nail the position. I think what we're seeing is that what we thought maybe 10 years ago was this kind of niche application for certain modalities has really broad-based applications. And now when you think about what you can actually do with that imaging data, going into software, doing things like a facially driven smile design, right? Layering in the CBCT scan, the intraoral scan for complete diagnosis and treatment planning across multiple vertical modalities, and then take that same relevant information all the way through the workflow from diagnosis to delivery, it becomes pretty compelling that this is going to become more and more part of every patient's journey as the industry evolves.
Dr. Fenton.
I agree. I think it's procedural and I think it's situational. I wouldn't say that every patient that walks through the door is scanned. I think it's dependent on the services they need and the treatment options that can be plausibly given. We do have those patients out there that are just simply unaware or uneducated from a radiation standpoint, right? And we'll get a little bit of concern as to, hey doc, is this going to be harmful to me? I'd rather not right now, right? And being that the transmission is 9 to 120 microsieverts, we really communicate to the patient that they're exposed to more radiation when they walk, out to the parking lot under the sun to get back to their car, right? It's a relatively,
especially in Florida.
Yeah, exactly. Especially down here in sunny South Florida. So, we try to, supplement those conversations with fact. And I think that once we're arming the patient with knowledge, then it brings down that barrier as to their compliance and our ability to scan them. But like Doc was saying, from an impacted third molar, from a bifurcated maxillary molar and proximity to sinus, it's a cross specialty tool that depending on what the patient has going on and what exists, that we make the determination to provide the scan.
Ryan, what are you saying?
I couldn't agree more. I don't have much else to say other than, echoing what the doctors just said. There are applications for cone beam CT across the dental spectrum. 10 years ago, 12 years ago, I'd be at a trade show and I'd try to talk to a doctor about cone beam and they would dismiss me immediately saying, oh, I don't need cone beam, I don't place implants. Well, that's not the world we live in anymore. The only other thing I would say is that I speak to more and more dentists every single day who tell me, I wouldn't place an implant today without a cone beam. Or I just spoke to an endodontist yesterday who said, yes, I do a small field cone beam on every one of my endo patients because of the value that I get. You can't just make a blanket statement, but for the most part, that's the way things are going. And I just echo everything that Dr. Rawal and Dr. Fenton said as well.
What I will say, Bill, is, and we briefly spoke of, getting the doctor to yes, as far as confidence and as far as his willingness to perform certain procedures. I think it's been a tremendous tool for us during the patient consultation phase of getting the patient to yes. And I think that by having that scan visible in the consult room and taking them through, not too technically, but being able to show them things like that you are up to date on the technology and really walking them through the imaging, it becomes more than just a take my word for it because I'm the doctor's situation, right? When you're able to convey the value of the treatment and why the patient is or is not a candidate for dental implants or for whatever procedure based on bone volume and quality, it goes a long way. And I think that we can hang our hat a lot of times on being able to make that connection with the patient secondary to the CT explanation and it really you really see the light bulb go off frequently when utilized in that way for treatment planning.
That's great. That you answered the next question that I had here. So we've got about 7 minutes left. So I was going through the list of questions that the audience had asked, and one was about case acceptance, which you certainly answered. That's, are you finding that it's kind of like show versus tell? I mean, is that as simple as it is with this case acceptance?
I think it's, oh, sorry, go ahead.
No, I was just gonna also, reiterate that it's a direct indicator for the patient to look at the dentist from a perspective of credibility. I think it's a large credibility indicator, and there's a lot to be said for that from a doctor to patient standpoint when we're using the CT scan to explain what we found. Go ahead, Doc. Sorry to cut you off there.
No, I was going to say essentially the same thing. I think our patients today are for the most part savvy consumers. If you think about the fact that probably 90% of them purchase at least something online today. At the end of the day, the reality is if you look at what a patient demographic was 10 years ago or 15 years ago, that would have been 1%. And so you look at a population that today that lives in a world where technology enables them to do the things they want, brings convenience to their life, brings value to their life. I think that there's that expectation that you go to your healthcare provider, and specifically in our situation in the dental field, and that you see that your providers are able to leverage technology the same way. So I think to Dr. Fenton's points, it's absolutely a credibility factor. It's absolutely something that enhances that initial trust that a patient will have with the clinician, because they see that the clinician is innovating and is forward thinking in what they're doing and embracing technologies that they are similarly embracing throughout society. And so from that standpoint, I think it only enhances case acceptance.
So a couple final questions here, and I'll let you all get a last word in, but one question, and this may apply a little bit more to affordable, although we could even talk about it from Aspen's perspective too, since you're more de novo. And I guess affordable, you're a combination of the two, right? You do acquire some practices. What are you doing, or just give a little bit of guidance if you're acquiring a practice? I mean, and we know some of the practices out there can be a little dated. What are you doing? I mean, are you saying, hey, we should probably add 3D, or is it kind of on a case by case or patient-based basis? What does affordable look at now when you're acquiring a practice?
Yeah, so that's a great question, and I'm going to give my best answer since I'm not directly involved in that process, nor am I part of that team. But for the most part, the practices that we do acquire, they're implant heavy practices, and usually it comes along with a shoe-in of utilizing this technology. There have been some smaller groups that we re-implement our partnerships and leverage the existing sort of deals and purchasing power and partnerships that we have in place. But for the most part, it's a pretty seamless integration. And again, I think it all comes back to the perception of value and explaining and having the doctor portray why this instrument is going to better them as a clinician, and how it's going to provide the better result to the patient.
That's great. So what I'll do here is we've got about 3 minutes left, and hopefully I'm sharing my screen. I wanted to make sure that everybody got a final say, anything that we might have left out that you wanted to, convey to the audience. But we have email addresses here. So if anybody wants to reach out to Dr. Fenton, Dr. Rawal, Ryan, or myself with any questions or comments, please do. We're almost up to the top of the hour, 3 more minutes. So Dr. Fenton, I'll start with you. Any final words, and then Dr. Rawal, and we'll let Ryan, since Carestream is sponsoring this, have the last and final word.
You know what? I was thinking about the audience, and those that may be on the fence, or those that just may be looking for that golden bullet or that urge of absolution. And I think that if and when you make this decision, it's got to make sense, and you've got to do it at a time where you don't feel like it's forced, but where you feel like it's appropriate. And then when you do, more importantly, decide to implement, I would give the advice to start slowly in terms of, expanding and cultivating the education to your existing networks. For example, use a smaller sample size, introduce it to a more intimate pilot, have the docs champion a staff member or two to first learn, and then pass that knowledge on to existing staff members versus trying to train them all at once from an efficiency standpoint and to mitigate the amount of confusion or legwork. So I'm wholeheartedly a proponent of 3D technology, and I strongly support and urge you to do the same. But there's a time for everyone to take that leap, and only you can be the the facilitator of that time.
Excellent. Dr. Rawal.
No, I kind of echo Dr. Fenton's sentiments. It certainly is an exciting time in dentistry. I think technology is changing everything that we do and how we deliver care to patients. And the reality is, one of the early stages of the digital process that we were able to implement technology was in diagnostics and data acquisition, and across, both intraoral scanning and CBCT technology. The reality is we've had this now for, almost 2 decades. I have to say, I think that CBCT technology is part and parcel of what I would consider to be a contemporary, innovative practice to offer care to patients. And I think that, for me, it's really all about making sure that you partner with people like Carestream who have the ability to scale and grow with you, to help support, integrate, and implement with you, has a full breadth and scope of a solution that transcends just the acquisition aspects and moves into more of the complete digital ecosystem. And if you look at all of the landscape today, finding that right partner for you is going to allow you to make some of these innovation adoptions faster, make them more predictable, easier to implement, obviously increase the ROI that you gain with more effective results earlier. So there's a lot to be said about the technology, and I certainly am a big proponent, and just excited to be able to talk about it for a little bit here today. Thank you.
Thanks, Dr. Rawal. Ryan, last word.
Thank you so much, Bill, for your moderation, and I couldn't agree more with Dr. Fenton and Dr. Rawal. This is powerful, exciting, truly game-changing technology, but it's only as powerful as you know how to utilize it. And Carestream's here to help with that. We're here to be your partner and to get you started and to stay with you all the way through. It's exciting, and thank you for highlighting it today. Pleasure to be here.
Absolutely. Well, thanks to Dr. Daniel Fenton from Affordable Care. We have Dr. Sundeep Rawal from Aspen Dental and Ryan Roosekrans from Carestream Dental. Thanks everybody for participating. Thank you to the attendees. If you want to share this recording with any of your colleagues that didn't have a chance to sit through this live, it will be up on the groupdentistrynow.com website under webinars. So thanks again, everybody, for spending an hour with us on the Group Dentistry Now DSO Study Club webinar series. Until next time, I am Bill Newman. We appreciate it.